background noise that immunization in lupus patients would trigger lupus flares, but there have been careful studies from the CDC in Atlanta and many other studies that suggested whilst these cases do occur, on the whole they're very rare, and we should offer our patients the benefit of immunization. And obviously we need to pay very close attention to cardiovascular risks. So a couple of other pointers now, just a few other points of time. This is a different story. Young woman, age 24, now age 17, she developed classical lupus, responded to steroids, and then switched to hydroxychloroquine and stayed on hydroxychloroquine. Did very well. No problems there. She then presents with a very insidious onset of breathlessness, no cough, she was antiphospholipid antibody negative, and you can see here that her chest X-ray is very abnormal. She's got a rather prominent right atrium there. Her ECG was very abnormal, showing right ventricular strain. The obvious question was she having multiple pulmonary emboli? She had a CT pulmonary angiogram which showed no pulmonary emboli, but a very, very dilated pulmonary artery. It was bigger than the aorta, so that was clearly a dilated pulmonary artery. And further down the scan, you can see that both the right atrium and the right ventricle are grossly dilated compared to another patient with a normal scan. And this patient had pulmonary hypertension. This is a very rare manifestation in lupus, I'll give you some data in a minute, but you need to be aware of it, because it is now at least treatable. So the clinicals, usually these patients present with breathlessness, or they have signs of cardiac failure. These are the usual tests that we do: chest X-ray, D-dimer, blood gases, saturations, CTPA if needed, ECG, investigations for pulmonary emboli, and as an outcome measure, we do 6-minute walk tests on all these patients. And increasingly now we're using the NT-proBNP as a marker to measure heart strain, if you like. And these patients all should have a right heart catheter. I work very closely with Jerry Coughlin, who's a cardiologist from the Royal Free Hospital. He comes to do a clinic with me every month, and his particular forte, he's a national expert on pulmonary hypertension, and I've learned a lot from him. So what about pulmonary hypertension in lupus? It's a very rare phenomenon. I think it's about 1%. This is 14% is a gross overestimate in my view. It's about 1% of patients. The pathogenesis, it's clearly immunologically mediated inflammation, and survival is terrible. 45% at 3 years and 17% at 5 years. And in fact, this young woman, who was only age 24, her PA pressure was nearly 60, and we thought she'd be dead in 18 months. She's not. In fact, she's alive and well, and doing extremely well on therapy, which I'll come to in a minute. Survival is a bit worse. If you look at the survival of patients with lupus and pulmonary hypertension compared to idiopathic pulmonary arterial hypertension, survival is a bit worse. But it's better than scleroderma. So scleroderma is terrible. So if you have scleroderma-associated pulmonary hypertension, they are the worst category of all. And at least lupus patients, their survival function tends to be better. Pathology, we think, is similar to that in idiopathic pulmonary hypertension: plexiform lesions, medial hypertrophy, intimal proliferation and fibrosis, and elevated endothelium levels, a characteristic of whether this is idiopathic or lupus related. Associations of pulmonary hypertension: Raynaud's, abnormal capillary loops, you can see here, and antiphospholipid antibodies are definitely associated with pulmonary hypertension, and not necessarily with thrombosis either. Treatment: these patients do need to be seen in a specialist clinic. They tend to be all anticoagulated. This is again another evidence-free zone. I asked Jerry, why are these patients anticoagulated? He just shrugged his shoulders and said, that's what we do. There is no evidence for it, but that's what happens. But there is now very good trial evidence for these treatments. These are endothelin receptor antagonists. Some are dual blockers, and some are single blockers. And sildenafil, as you know, Viagra, is a licensed treatment now for pulmonary hypertension. So bosentan, ambrisentan, prostacyclins are now standard treatments. Cytaxantan was licensed, but a couple of weeks ago was withdrawn because there were several deaths from liver failure. So cytaxantan has been withdrawn. So these are treatments that we have available for patients, and our patient is doing well on a combination of sildenafil and bosentan. So moving on rapidly, actually, when I talk about